Assalamu alaikum everyone. My name is Dr. Al-Mahtani. I'm an interventional structural cardiologist from King Salman Center, King Fahd University, Riyadh. It is my job honor to be the host of your sessions today. Joining me in this case, my scrub nurse, Abdullah Bashir, my security nurse, Wael Chilin, and also Shahad Shimri. We have Oxley, Ayat Ahmad, and we have also the supporting team from the technical side. We have our CBT, Wisdom and Tayri, and we have today for an interesting patient that is going to undergo renal innovation. We have today a young gentleman, 36 years old, who has infiltrated augmentation for the last few years. He was diagnosed in November 2019 with acute myocarditis MCS stroke. At that time, I was found to have significant elevated blood pressure, with his systolic which is the 190 to 100. He underwent a 12-hour scrap at that time from the identifying point of view, pathology point of view, and also the Pascal point of view to look for secondary diagnosis of hypertension. There was nothing found, endocrine causes including Cushing, pituitary, non-evolutions, and also hyperthyroidism were excluded. There was no evidence of renal or adrenal gland issues. Ultrasound of his kidney showed no evidence of renal stenosis. It was also seen by pathology for possible rheumatoid causes, and that was ruled out. Eventually, he was diagnosed with essential hypertension, and his stroke was secondary to uncontrolled hypertension that was for years present and was left out.
So briefly, he's a young guy, 36, no risk factor except stroke. In 2019, he had a stroke. At that time, a workup to rule out rheumatological causes for his stroke was conducted. Nothing. Endocrine causes for his significantly elevated blood pressure. Systolic blood pressure was between 190 to 200. There was no clear causes for his stroke apart from the possible underlying hypertension. He was initiated on the appropriate therapy, and we'll tell you about them now.
He's currently on 3 medications. He's on maximum dose of Atarada. He's taking 90 milligrams of daily. He's also taking up to 75 to 100 milligrams of hydroxyzine 3 times daily. And he takes every circuit 20 milligrams once daily. He cannot take the diuretics, and to be unable with the diuretics that he took with hydroperoxide reach up to 130 and 40. And therefore he's off that, and currently with those 3 medications, the blood pressure systolic ranging between 150 to 170. This is his blood pressure now in the cath lab and phase. He has lots of pain in the phase down yet. Once we obtain
So blood pressure baseline in the cath lab before we used the invasive was 172 over 94 over while he's taken all those medication, hydrolysine 75 TID, he takes Irbesartan 300, and he takes also Adalat at 90, and those are maximum doses, and this, the medications he's been on them for the last 1 year.
The diet will see what your blood pressure like. So we obtain ISIS on the right renal arteries using ultrasound guidance. We see 2 arterial flow, so the superficial and above level, and then we find a point where they hypo join together. This is the point where they join together. Okay, and you can see them both sides. And this is the area we're going to go. You're going to freeze this area. Okay, and then manage obtain access. After this, okay, sharp. Okay, stop. Okay. Okay. Stay away from the camera. So now I'm gonna get access by making sure you get it to the right spot. Okay. So this is where I puncture Malaysia under ultrasound guidance. You can see us just coming anteriorly images, and we're gonna have gain access. And this is the blood directly coming, and we're gonna basically obtain our system. 6 pressures. Good. Okay. Triglyceride. Okay, ultrasound I'm done. You can take the ultrasound first. As you can see here, this is the signs of blood pressure of this patient, despite maintaining the medication. This is his blood pressure. Might be slightly anxious, as is currently in this procedure rule, but those are the number will be staying. And we're going to start by sedating and give her some sedation in control because this procedure is painful.
So the monitor is cutting off. It's not showing you the live feed, but it's reaching up to 190 systolic inside the cath lab, given that he's also anxious. We have not sedated the patient yet or given him any opioid. So the blood pressure is partly will decrease due to sedation when you give him that.
And once we achieve that, we get him some pain control, then we're going to proceed by doing the first step in this equation, which is doing an aortogram at the level of renal arteries to delineate if there is evidence of accessory artery. Yeah, there's a big catheter. That's the first step. Come down on it, let's say, to a level where you think the renal can be is rotating. Okay, and then we will take an aortogram to delineate the presence or absence of accessory artery, and also to delineate also the cause of the renal arteries. So we don't want to do this step if you already kind of done a CPA of the renal artery in the abdominal aorta, or if you've done an MRI, because at that time you could delineate the presence or the absence of renal accessory arteries.
So the whole point of doing an aortogram at the level of the renal artery is to delineate if there is a presence of accessory renal artery. You could avoid that if you've done a CTA beforehand for planning or MRI. But if it is not done, personally, I do it as part of the procedure. I do the aortogram just to see the renal arteries and if there is presence of accessory, because if that's present, then you need to consider that artery for ablation.
Okay. This is an aortogram at the level of the renal artery. We can see an unselective filling of the white renal artery. I don't see any accessory artery. And moreover, on the left side, we can see there is an accessory renal artery, the renal artery.
You can see this at the left kidney has an accessory renal branch.
When we go to the left side, we have to check both arteries, and we have to do both of them in terms of calculation. So the next step is to go selective, and we'll start out the white kidney. In terms of the procedure, the system that we're going to use, first, after doing the aortogram, you are delineating the arteries that you lead away. Then the next step is to take a short DME catheter that is 55 centimeters. You advance it to the level of the renal artery on one way, they engage selectively. After engage selectively, then you'll get basically nitroglycerides to dilate this arteries. You're supposed to apply, okay, this is very important, distally to proximal, as long as you don't go into the periphery. As long as you are in the distal artery, but not in the periphery, and they are only 3 millimeters, and less than 3 millimeters per picture of that.
So this is an important point that I want to reiterate again. So the catheter that you're going to use commonly is a short form of a Lima catheter. It's 55 centimeters. It allows you to reach the renal artery without trouble. If you use the long one, it might be a bit difficult to deliver your catheter because most of the system will be outside. That's number one. The coronary wire has to be a stiff wire, so Grand Slam is a good choice for those patients. You can use BHW, balanced heavyweight wire as well, but Grand Slam is a good option. The catheter itself, once you advance the catheter, which is the Simplicity spiral catheter, you need to try to be in the distal part of the renal artery branches, but not within the parenchyma, because the nerves commonly, when they emerge around the renal artery, they are a bit distant from it further out, and they start to converge around the distal part of the renal artery branches. So the best benefit you're going to give your patient is trying to ablate in the distal part of the branches of the renal artery, not within the parenchyma.
You should avoid osteal areas, and you should avoid also terrain or bifurcating area. Those are nothing you should avoid. You deliver the catheter, which we will show you the catheter, to deliver the ablation catheter or the denervation catheter. Over in a coronary wire, stiff coronary wire slam is an option. This is basically the system that the catheter that you're going to connect to the generator. And once you connect it, and you have the good inside with this spiral catheter, which basically has 4 areas that can provide the ablation, and it goes with a spiral shape, which you pull the wire, then you're good. And you do it for at least 40 seconds, up to 1 minute. So this is the procedure in summary. I will start out by obtaining a selective engagement of the right item. This is the catheter that we use. This is the spiral catheter. And then it's the catheter is the ablation. It has cord connections and then basically a handle that you can manipulate the rotation. And you connect it to the console where you can choose the frequency and monitor the ablation time. This is, as you can see, it is the catheter, the spiral catheter. I'm just going to try to make it more clear for you. Can you zoom on this? And then,
So the tip of spiral catheter has 4 electrodes. They are the one who's generating electricity and conducting it through the renal artery to reach the peripheral nerves that surround the renal arteries and hopefully causing demyelination and severing those nerves.
John, I'm going to ask because where they are that spiral over the super stiff courier wires. In this case, the granules. You need to be in the distal branches of the renal artery in order to deliver this above. Sometimes it might be challenging. Sometimes you might disable the support wire abilities like that. But trying to get to the distal part of the renal arteries are very important. Support device.
So this is loading the catheter. There is part of the catheter has this yellow cap that allows you to load the catheter easily over the stiff wire.
Yeah, to be able to load it. But once you've done that, then you no longer need this support part. And it's basically a robotic exchange system, similar to what you have algorithm. Click the silver button over to the next. Sure. Okay, that's fine. And then you deliver it to the renal artery until you get to the point where you think it's appropriate to start out like this.
So you see the coronary wire or the grand slam is already in one of the branches. We've taken a picture, but it's not showing here. We normally give nitroglycerin just before we decide which artery to go after, just to expand them to dilate them to the proper size, because the minimum that you can ablate is a 3 millimeter branch.
Okay.
We use a reference. Some cath lab has a red heat map that show the branches, and you don't have to keep injecting contrast. That's to minimize contrast as much as possible. Renal impaired patients are contraindicated in this procedure. However, there is off-label use in patients with CO2 angiography, and possibly we'll talk about that later.
So here we are advancing, as we can see on the monitor. We advance as all the way to the distal point where we think it's more appropriate to send it. Sure. Then.
So what you see on the left corner below, it's the impedance, it's the electricity conducting through the nerves. And what you need to see is the stability of the signal to say that you're in a good contact with the renal artery and the impedance that is reflected there.
It was the row. So the distal part, you can see here, okay? So we have this part now. So as you can see, this is the first spot where we will be ablating. So once you get the spiral catheter to the polycoronary-like level, then you see here there are basically four points. Those refers one on each electrode from distal to proximal. And this is basically the trigger for radiofrequency ablation for the whole procedure. And in the monitor, you could see basically the area will act with each electrode, and as long as you see stability, then you're basically staying in. Okay. And this is a painful procedure of time, so a judicious use of sedation and pain control is very important.
So I want to reiterate, it is a painful procedure. Patient will experience a lot of pain through the procedure when you ablate. So preemptive use of fentanyl or any opioid of your choice, along with some sedation, is very helpful in those patients. But don't confuse the use of sedation and drop of blood pressure during the procedure related to sedation to that of the effect of the procedure. Most of the time, we don't see any result until 1 month from ablation. But you need to give them a very good dose of pain control.
هتست شوية أبعاد كل كيف الأبعاد. We start on.
So this is once you turn on the ablation, if the heat is below certain level or above certain level, or if the contact becomes loose, the electrode automatically will turn off and will not continue ablating. And in this case, you can see number 2 and number 3 did not really give a good ablation, so they discontinued within their algorithm. The system recognized that, so it stopped. And then what we do is we go again and repeat number 2 and 3.
So we're gonna discard basically turn off the first and the fourth electrode. We'll keep the second and third electrode running, and we're gonna go for the second one.
This takes up to 1 minute, so you need at least minimum 40 seconds to consider ablation effective in that area.
Currently, so we finished one of the main distal branches. Okay, we're gonna try to go to an upper promotion.
So we go from distal to proximal, and we try to avoid ostial or bifurcating points with the electrode.
Okay, so we finished 2 main branches, and now we are moving to the main proximal part of the renal artery, and all of those radiofrequency ablation electrodes are in good position. So we're going ahead and give him a final ablation to the right kidney, giving him a total of possible 12 ablation points. So we had 1 point of no good contact, so we have to repeat number 2. And we're going to turn off the electrode number 1, 3, and 4. We're just going to keep number 2. Okay? Just confirm position is okay. I think position is okay. And sometimes you can use the knob to just adjust if you think the contact area is not great. All what you need is a steady tracing. You don't want to have too much jittery movement or abnormal movement. So you just want it to be steady as much as possible. Okay? Now we have concluded.
So what you see on the right side here, those numbers. So this is the impedance, and this is the heat. So how much heat generated, and the impedance from baseline, how much did it drop? 4%. It's hard for us to reflect on those numbers to say, okay, if it dropped 4% up or 10% or 20%, which one will give an effect? It's hard to know that. We don't have data on that yet. But as long as you see drop in the impedance and increase in the heat signal, then you're good with ablation.
The right renal artery ablation, we did a total of 12 ablation points, and now we just need to confirm that there is no issues within the artery, no dissection, nothing. So we just take a final.
So once you finish, you need to make sure that there is no complication from the intervention itself. So no dissection, no perforation, things like that, and you have to be ready to deal with them if they happen.
No shots. Okay.
That is.
This is a final angiogram of the renal arteries.
Final shot.
And we see no problems at all.
Kidney. Okay. We're gonna move now to the left kidney. And in the left kidney, as we mentioned, there was 2 spots that we need to address, our 2 renal artery, the main and the accessory. Okay, so section, now we started with the left kidney. We're gonna be doing the lower part of the renal artery branch there. and we're going to do only a 3 ablation electrode. The distal one is very close to the parenchyma, so we'll disregard that. Okay, starting.
So we finish the first branch, we go into the second branch, and then we starting from distal to proximal as usual. If we think the electrode is in an area where it's close to the parenchyma, we might just turn off that electrode instead of pulling the whole system. Because sometimes we have to avoid the carina,
Discard the number 1.
and we are governed by a specific position.
Right.
Yeah. So we're doing now the upper part of the left renal artery branch.
We have 2 minutes to finish this.
We're going to discard also the distal one because it's close to the parenchyma. So we're doing 3.
Sorry, can you remove the thank you? Thank you. Just give us 4 minutes more.
We have 2 minutes. Then
Sure.
electrodes only.
So we go in the same. We're doing the same with the renal. Then we go to the accessory branch. We're doing the same, and
Taking a final shot of the accessory left renal artery after completing that, and then we'll show you what's the hemodynamic like at the end of the procedure. We have concluded our procedure. As you can see on the monitor, his blood pressure now at the end of the procedure is 117/63. We started with 160, 170. Again, this partly also due to the effect of the sedation we have, but this is sometimes we see an acute effect of the ablation when we do it right away. Patient will be back on his regular medications and will possibly going to stop his hydralazine and keep him to medication and see what his pressure doing in the next few days up to 1 month. That's the normal period where we see the effect. Once we see that his blood pressure continues to drop further, then we will discontinue medication one by one. I would like to take this opportunity to thank Medtronic for their effort and bringing this case along and supporting it. They've been quite supportive to us. Also, I would like to thank the team that's present here, Manal Al-Dosri, who's been our ally when we do those cases. I'd like to thank my team, Abdul Bashir, my scrub nurse, Raed Al-Sulami, and Shahad Al-Shihri, our circulating nurses, Khairat Madkhali, who's our X-ray, and Abdul Mtari, our CBT. I'd like to thank King Fahd Medical City in general, specifically King Salman Heart Center, for supporting us through those cases and for allowing us to continue to show our work and educational cases to the region and to the world. Thank you so much.
thank you.